Hello, I'm Tony DeMaria, the editor of JACC, here with the highlights of the August 28th issue. Now, association has been reported between obesity and atrial fibrillation. Of course, obesity is associated with a number of other abnormalities such as coronary artery disease, hypertension, diabetes, obstructive sleep apnea, etc. And so the question exists, is the association of obesity with atrial fibrillation related to some electrophysiologic or hemodynamic effects directly due to the obesity. And to study that, the group from the Mayo Clinic looked at 63 patients undergoing ablation, and they divided these patients into a group who had a BMI of less than 25 kilograms per meter squared, and a group of obese patients with a BMI of greater than 30 kilograms per meter squared. And in comparing these two groups, they found some interesting electrophysiological differences. There was a shorter effective refractory period, both in the left atrium and the pulmonary veins. In addition, there was higher left ventricular volume and pressure in the left atrium of obese patients, and lower left ventricular myocardial performance as manifested by longitudinal strain measurements in the obese patients as well. So some evidence that obesity may have some direct effect in provoking atrial fibrillation, and yet another reason for us to strongly attempt weight reduction in our patients. A very interesting article from the August 21 issue of JACC deals with the prophylactic therapy of advanced mitral regurgitation with beta-adrenergic blockers. And we all know that there really is no medical therapy that has proven to be effective in reducing LV remodeling or the appearance of left ventricular dysfunction in patients with advanced mitral regurg. And so the group from the University of Alabama took a group of patients with advanced mitral regurgitation who were asymptomatic and did not meet criteria for surgery, and randomized those patients either to beta-adrenergic blockade therapy with metoprolol or placebo. They studied the effects of this therapy by magnetic resonance imaging, and what they found was that at the end of 2 years, there was a significant benefit in terms of ejection fraction and the maximal rate of left ventricular early diastolic filling. Now, in terms of structure, they really were unable to detect any changes in left ventricular volumes or strain. Perhaps most fascinating, but least statistically significant in this small group of patients, 6 patients assigned to placebo required surgery over the 2-year period, whereas only 2 patients treated with beta blockers needed surgery. Now, clearly this is not statistically significant, and the clinical implications of beta-adrenergic therapy in patients with advanced mitral regurgitation remain uncertain. Nevertheless, it's an intriguing possibility to alter the course of this disease. The treatment of pulmonary artery hypertension remains challenging, and a role has been shown for phosphodiesterase inhibitors. Now, tadalafil is the phosphodiesterase inhibitor with the longest duration of action, and so it would have some attraction for the treatment of pulmonary artery hypertensive patients if it were effective. And there are data, and it has been approved at a 40 milligram dose for treatment in patients with pulmonary hypertension based upon a short-term 16-week study. And now in JACC, we have a full 1-year, 52-week study where patients with tadalafil at 40 milligrams were followed carefully, and the investigators were able to show an increase in the 6-minute walk time and fewer clinical deterioration events in these patients who were on tadalafil treatment. Now, we have to be cautious because there was no placebo control group in this extended trial, and those patients who had not experienced a benefit or had a side effect with tadalafil in the short early trial were excluded. Nevertheless, I think we now have some substantial data that we can treat our patients with pulmonary hypertension with tadalafil and expect good results. We were pleased to have these interesting papers to publish in JACC. For Inside JACC, I'm Tony DeMaria.